Welcome all of you to this live program at Orthopedic Principles. Today our guest of honor is Professor Lyndon from Liverpool, United Kingdom. Professor Mason qualified from the University of Wales College of Medicine, completing his orthopedic training in Wales before moving to Liverpool as a consultant. Before joining Liverpool University Hospital NHS Foundation Trust, Professor Mason completed the BOFAS traveling fellowships in US and Germany. In the Liverpool, Professor Mason obtained the BOFAS Gold Fellowship Award. Professor Mason has been awarded the Hungarian Professorship from the Royal College of Surgeons in 2020 for his work on ankle fractures, the Robert Jones Gold Medal, and the Jacques Dubois Award from the IFOD, and also the Chanson Memorial Prize from BOFAS. Professor Mason is an honorary consultant professor at the University of Liverpool and is an invited faculty member for courses run by the BOA, the BOFAS, and the Royal College. Professor Mason sits on the council for the BOFAS as Outcomes Committee Chair, taking responsibility for the National Foot and Ankle Registry. If you've noticed, Professor Mason has delivered a couple of lectures on our channel. It's already reached a huge audience. And today is my great honor to bring back Professor Lyndon Mason for this wonderful live program. Over to you, Lyndon.
Thank you very much, Tash. Thanks for the invite again. So I guess I need to put a caveat for Achilles tendon ruptures for this moment. I have a great bias towards not fixing them. But that is also based on the fact that we have an Achilles tendon rupture clinic within Liverpool, which is run by expert physiotherapists, initially by Phil Ellison, who's now left us, and Paula Gowdy and Dan Scarf are the ones who now run it. And therefore, our results are based on the fact of having an Achilles clinic, which not everyone will have. So I'll go through the anatomy, the pathology, diagnosis, and treatment, and also at the end, I will go over chronic Achilles tendon ruptures also. So first of all, the anatomy. So the triceps suri is the confluence of your gastrocnemius and your soleus muscles. As they descend towards the calcaneal tuberosity, they do rotate. There's a few studies, including one from Liverpool, so my colleague Andy Malloy, where they look at the tendon from each head of gastrocnemius and the soleus and see where they insert. And actually, the medial head of your gastrocnemius is the most posteriorly inserted onto the tuberosity, which is why we feel that a medial head of gastrocnemius release gives you some of the greatest amount of improvement with gastrocnemius tightness. Also on is its arterial supply. So your proximal and distal comes from your posterior tibial artery, and the area which is often talked about being the least vascular, it comes from your peroneal artery. This is the middle portion. Pathomechanics. So the incidence of ruptures is quite common, 6 to 10 out of 100,000. 75% of Achilles tendon ruptures are related to sports compared to 2% ruptures of other tendons. Histology, most will have degeneration beforehand, and if you quiz the patients of what their symptoms were like before they had the rupture, they'll often say that they were symptomatic. Higher in sedentary lifestyle, and we got a bit of work on this now, the weekend warrior effect. So people who have a sedentary lifestyle have work mostly sitting down and then compete in sports once a week. Unfortunately, I'm one of those myself. I will be doing a five-side football tonight, even though I've sat on my butt all weekend. Males more common than females, young more common than old. But what is young and old is the question. You have these extrinsic and extrinsic factors. You'll have overuse type symptoms, alterations become worse. You get a partial rupture, and then you get complete tendon rupture. And most literature talks about it as being greater than 8% strain. So this is one's taken from the internet of a American footballer. You can see the pop as it's, and it's usually this on eccentric stretching that you get the rupture. So next, the diagnosis. So the first presentation is quite stereotypical, where most of them will say they were playing some type of sport and they felt like they were shot by a sniper, or they had a hit by a racket on the back of their heel and they felt something go. They often hear a loud bang. Sometimes the people around them hear it also, and they're unable to walk afterwards. And mostly, as I said, in sedentary lifestyle. It's not always this way, and people who don't describe this as the typical description sometimes require further imaging. Pre-existing conditions such as rheumatoid, gout, ankylosing spondylitis. In our study, and I'll describe this a bit later, where we're looking at the mechanism of injury, around about 40% will have comorbidity. Fluoroquinolone and phenytoin are the medications that can increase the rupture rate. We've had 2 of these in the last 3 years. Often they come with bilateral when they do, and the strong association with blood group O. This is your typical weekend warrior, as I said. One's always sitting down job. This is from our own study. So looking at over 200 Achilles tendon ruptures from Liverpool, looking at how they did it, and you can see that these are all different sports they did it in. But look at the age groups. Running, the average age was 60. The average age of football was around about 40. The average age of dancing was over 50. So these, in your normal classical Achilles clinic, are not your elite athletes. This is what most people describe in their Achilles clinics, this type of age group over the age of 40. And so we looked at the occupational activity classification, which is a validated classification, where it tells you about all the different the exercise done within that. So, for example, if you're a fireman, you'd be in the high. If you're a taxi driver, you'd be in the low. And you can see that those that occurred in sport are almost all sort of in the low occupational activity classification, which gives you the line of the weekend warrior effect. Sometimes you have the palpable gap, not always, but you'll often get swelling and not the defined tendon at the back. Simmons or Thomas test, where you squeeze the calf, that causes it to be lifted away from the tibia and therefore will flex the foot. If you've got a disconnection between that and the foot, then you will have it won't move. This gives you an example of this. Remember that it's a chain, so your gastrocnemius gets tighter when your knee's in extension. So this is one of the cases I had from a few years ago. You can see on the right side, which is normal. On the left side, when you move this side, you can see you don't have that resistance because the Achilles is not got the resting tension. X-ray, so you can do an X-ray. I saw this on Twitter the other day, the Kager's fat pad sign. So you lose the triangle. As you can see, that there's other white arrows showing the gap, but also you lose this nice crisp triangle. The use of ultrasound and MRI. Now, I know ultrasound is used very often in a lot of Achilles clinic, but we don't. The conclusion of this, which was a systematic review, showed that most actually rely on clinical examination and only use it to rule out other injuries, and that's what we really do. I'll talk about gap next. So the Cambridge study looked at this, saying that there was a gap effect with if you had a greater than 1 centimeter, there was a effect on your ATRS. However, this study didn't find that at all, and my colleague Jit Mangwani from Leicester looked at this also, and also found that there was no correlation between gap and ATRS, but they did find a correlation between where it ruptured, so whether or not it ruptured close to the Achilles insertion at the calcaneum or further away, and the greater the further away, so this greater than 5 centimeters had a greater score. Now, it's important to know what you mean by gap. If you ask most radiologists what a gap is, when they scan it, they will scan from normal tendon to normal tendon. And actually, a tendon does not rupture as a laceration. It ruptures like seaweed, okay? And all you're measuring is the distance over which it is ruptured. You're not measuring an actual gap. You're measuring over the distance it's ruptured. And that's why, for me, it's nonsense. The other thing is that even if you repair them, so this was a study done, a randomized controlled study where they've done and put metal beads in and had a look at the different weight bearing. and found that it didn't matter if you weight bearing or not, or whether or not they were in immobilization or not, they all lengthened. And they all lengthened at the same, around about a centimeter of lengthening afterwards. So the next thing is going on to is treatment. So first of all, some basic science. So after 3 days, your type 1 collagen production increases 20-fold. Also, the collagen type 3 is the first abundant collagen. That's your reticular collagen, and then that gets converted to type 1 around about 2 weeks. So after 2 weeks, you have your fibrous bridge. So anything before 2 weeks is often seen as an acute rupture, but obviously you want to catch it right on day 1. And then anything after 2 weeks is seen as a chronic rupture, though the literature sometimes calls it 4 weeks. For me, it's 2 weeks and above that is seen as a chronic rupture. Between 3 and 4 weeks, the collagen begins to organize longitudinally. So you truly have missed the boat at that stage if you want to try and get the tendon ends together. So effective mobilization. So healing tendons undergo passive motion, will heal by intrinsic healing from tendon cells from the epitenon. But if you immobilize, it's predominantly by granulation tissue from the endotenon, and the collagen fiber cross-linking improves with applied stress. So if you keep someone, the traditional method of treatment was a plaster cast for 12 weeks. That's what I grew up using. But if you imagine that you do not put any tension through, then it will just be a ball of scar tissue. And it's no wonder why these ruptured afterwards, so why they had re-rupture. This is from studies on flexor tendons in rabbits, show that early functional movement does improve and decrease your re-rupture rate. So if you look at the historical studies, you favor open surgery due to re-rupture rate, and most people would quote back when I was starting a 10% re-rupture rate if you done conservative management, and down to 1% or 1 to 2% if you had functional rehab. However, this paper, which was from Belfast, this was the seminal paper for me that showed that with the functional management, they could reduce the rate down to the surgical type of rates, as you can see, down to 2.9%. I worked with Gavin Hayes, so he's now returned to Belfast, but he was in Liverpool with us for a short while. And then the Swansea protocol. So in the UK, the SMART protocol is used quite regularly. We use it with only slight tweaks in Liverpool. And this is the SMART protocol, as you can read here. So Anne-Marie Hutchison done a PhD on Achilles tendon ruptures. And if you want further information on that, on the Liverpool Foot and Ankle YouTube channel, she's done a great lecture on the rehabilitation of it with Phil Ellison, who's working with me at the time. And they found that with this functional rehab, the amount of conservative treatment increased, and the amount they were operating on decreased enormously. So this is our data. So this is straight off the press. So we've recently looked at this. Our re-rupture rate since we merged hospitals just before COVID, out of 214 patients was 2, which is 0.93%. This does include some delayed ruptures as well, 19 delayed ruptures within this data set. So I've looked at how many actually we operated on. So for those that weren't delayed, okay, we operated on 5. That included the 2 re-ruptures because they were both underwent surgery afterwards. And the other 3, some of them, one was a laceration and the other 2 were the insertional tendon ruptures. So you can see that we mostly treat them conservatively with functional rehab. The delayed ruptures, however, these, even though these all go through a SMART protocol, but 40% will fail the SMART protocol and require surgery. The LEAP study, which, sorry, the LAMP protocol, which is from Leicester, it's got slight tweaks as compared to the SMART protocol. Mostly that's they go in right to the start. Again, they showed very good results up to 23 months post-injury. So, but what's the aim of the functional management? So I think most people would agree is to achieve the appropriate tendon length to allow the muscular capacity and function. But therefore, you're reliant on an appropriate position in the orthosis and tendon in that position. This is where the literature becomes very problematic of what people are using. As you can see, all these different studies are using different types of orthoses. different methods, and we will go through this now. So this was a paper that we done back in 2017. So fellow Ellison was our specialist physio at that time, run the clinic, and he just felt that the wedges just weren't doing the job. So we started x-raying them. And you can see here that if you had a boot from externally, then your ankle was flexed and the tendon ends would be opposed. But if you had this platform at the top, then the ankle just was normal, and you had Aquinas through the midfoot. So there was no different putting someone in a wedge than it was to actually putting someone in a normal boot, and you would not get that Achilles shortening with it. This was the graph from the paper showing that control group with wedges was virtually identical to just having a normal boot. But then when you had external Aquinas boot and cast, you had a much greater degree of angulation. This has been repeated this year, just last year, and they actually found that the wedges without the platform, so this is a wedge with the platform, wedges without the platform could give you the same as the Aquinas boot, but wedges with a platform do not. You put a plaster brace? So there's no different in ATRS, but in this study they didn't have a re-rupture rate, but I would question the boot that they were using, because this was the boot they're using, which is not something that I think is appropriate. And then you look at post-operative complications. So if you are going to operate, then how often would you have a problem? So most studies say around about 10 to 15%. And there's increased risk factors such as age, active tobacco use, and specific specialty training, so who they are operated on by. You can see here wound problems. If you were non-trauma or trauma related, so this is the surgeon. Yeah, if you were the surgeon who was a non-trauma, you had a less wound problem than someone who was trauma related, for example. And this is what you're trying to avoid, which can be quite devastating. I give the example of Santi Carzola, who had an Achilles tendon rupture, operated on, and obviously had to have a graft from his arm. So then you go, okay, surgical and non-surgical. So you got many randomized control trials now showing the same thing, that if you look at re-ruptures are equivalent if the early range of motion exercise protocol was performed, and functional results were no different. What about MIS? So no different at 2 years, showing no difference across any of the functional scores. 5 meta-analysis, 3 including MIS, all these different methods of analysis. If all studies included, then you have the increased rate of rupture, but all report increased complications of surgery. And then this recently reported in the New England Journal of Medicine, again, showed no difference in function. Again, these actually use wedges with platforms. So even with that, you find that, okay, well, you're still getting reasonable results. This is from a BOFAS National Registry now, where it's the AS score showing no difference actually, but you can see a slight, almost increased trend in the conservative doing better than the MIS. The opens do include your chronics as well, but the ATRS, again, your conservatives seem to be doing better than your MRS and opens. So to move on to something else, the risk of DVT. There are 2 papers on this, and if you scan everyone, so not only including the symptomatic but the non-symptomatic DVTs, if you scan everyone, you're going to have a 50% chance of getting a clot. These are the 2 papers showing that. This is from our FATE trial, so this is about to publish on this, but it has been presented in AFS and EFAS, showing that of all the procedures we do in foot and ankle, the Achilles tendon ruptures have the highest rate of VTE symptomatically. So these do cross. It's a bit odd to seeing that surgery seems to be doing better than non-operative, but they are non-significant between each other. Does there any difference if you weight bear or not? No is the answer. So we expect that someone who is weight bearing would have a lower risk of VTE, but that's not the case when it comes to the Achilles. There's quite a few on these. And the next thing is delayed treatment. So those who produced the SMART protocol, so back to Swansea, showing that if they put their delayed protocol back through a rehab, a delayed presentation back through a rehab protocol, only 20% required surgery. Actually, we done it ourselves. We found it's 40% required surgery ourselves, but some of them do not require it, so it's still reasonable to put them back through a rehab protocol. Just to finish on for the acute ones, is return to play. There are a few papers on this on the elite athletes showing, and these are all in those that are repaired. In your elite athletes, you have around about a 60% chance of return to play. They've done it in NFL, in basketball, and also in soccer players. And this 60% is usually found that if you have someone who is the best, they are likely to return. But if you have someone who's just on the cusp of it, you may not return. Your time to return is so this is a systematic paper, a systematic review done this year, so just published on 24 studies reporting on patients. 65 to 100% of patients were able to return to sport between 3 and 13 months. So it's a big difference. And a lot of this is put down to psychology. I'll go through that now. And the incidence of re-rupture is very low for this. And this is the psychology. So there's very little done on psychology. I think psychology is really important when it comes to Achilles tendons in the elite athletes. So often they will come and say, look, I need suture material within my Achilles. I know the functional difference is no different. However, I don't feel I can rehab it without it in there. And this paper showed that this is a multi-center prospective cohort study. The psychological readiness at 6 and 12 months showed significant association with sports participation and performance. So it was the fear of re-rupturing and the fear that they didn't have this kinesia phobia, is the phobia of movement. And at 6 months, it was significantly associated with symptoms of physical activity. So they found that they would do something, would have some pain, and then they would stop. And motivation was highly associated with symptoms, physical activity, which is not really that surprising. So to discuss chronic Achilles tendon ruptures, I said in my book, this is from 2 weeks, but most of the literature still report from 4. Most studies represent level 4 data, or report good outcomes. So whatever works in your hands for this, really, I would suggest. The Den Hartog classification put it down as a defect of 2 centimeters. You can usually do a primary repair. Grade 2 is 2 to 5 centimeters. VY gastric, gastroc, not gastric recession. Grade 3, FGL transfer, auto allograft, and then you're talking about bone block. But often when you go in, you have a tendon. You have a tendon structure connected for the calcaneum to your muscle body, and what you have is a long tendon. So often you just resect in a section to shorten the tendon structure. This was an algorithm actually reported on this year, virtually identical. The one thing I would say that I'm virtually always now doing a flex tendon transfer and a allograft rather than autograft, and I'll explain why later. So if you are over 6 months, I would suggest an MRI and I'm looking for fatty infiltration for this, especially if you are not going to evoke a FGL transfer. V2I turn down, so they talk about maximum 5 centimeters you're going to do it. Again, reporting very good results. This study from China reported very good functional results as a consequence. Autologous versus allograft. So this is recently been published. They looked at whether or not they used their own tendon, and be it a VY turnaround or a tendon from elsewhere, or used one from the shelf, and found no difference, be it the, as you can see, the numbers are quite small. FGL transfer, so you're going to remove and just do an FGL transfer, then this is usually reserved for the elderly, but again, you can have very good results as a consequence. But in the younger, more active patients, you're unlikely to do FGL alone because you're worried about the state of the muscle itself and its relative excursion. So to give you an example of this, you can see the clear loss of rest and tension on the left side for this patient. This is the one I showed earlier. And this is my go-to. So I'll usually do an FGL transfer in front of this, first of all. You open up the Achilles, you resect the section that you require it, and then you bring the FGL in front of your tendo Achilles. And the reason for this is I find personally that that's where you get your tension, that's where you ensure that your foot's in the right position. And then I use an allograft to do a box graft. So I take this through multiple times in different directions as a biological repair. This is another example of doing this. I stitch it at either side. And personally, I've had extremely good results with this. So this is one we published on a little while ago. This was my colleague Andy Malloy's case. And you can see, again, this loss of tension in this patient. There's a large resection on this one. This one has not had an FGL transfer, so it's just a tendon graft, allografts that's been used. But you can see afterwards he's lost some tension. He was actually very good functionally, but I feel with the FGL transfer you can control that tension a lot better while you're doing the box graft. This is an example of one where there's been a large resection against my colleague Annie Malloy's FGL transfer. So to finish, in summary, Achilles tendon injuries occur the background degeneration. There's no apparent advantage of surgery if functional rehab is used. Functional rehab needs appropriate orthotics, and in the chronic tears with functional loss, any gap can be bridged by a number of different techniques. Thank you very much.
Thank you, Lyndon, for this evidence-based presentation. Truly, you've covered the entire spectrum. Lyndon, let's have a short Q&A.
Yeah.
Lyndon, I know you're a big advocate of a conservative approach to these problems. Do you think there's any benefit in operating younger patients, assuming that the re-rupture rates could be higher and they could get back to work earlier?
No is the answer. I don't think either of those concepts of re-rupture rate or getting back to work early are actually true. If you watch some Anne-Marie's professional sports players and what she's got them doing very early on, you will actually realize that you don't require surgery. So I'll give you a concept of this. So this is a lot of myths that's involved with in the sports med side. Now, as I said, we see quite large volumes of this through our Achilles clinic. And yes, these patients are not generally elite athletes. But you have patients who have been told that a gap makes a difference, even though that gap is nonsense because they measure the actual, so the length is ruptured over, not the actual gap. The second thing they're told, so you have someone who's got an Achilles tendon rupture, which is a consequence of usually tightness. So they've been tight and they've then had a rupture with a tendinopathy. And actually that's a treatment. And what you're going to go do, and you're going to cut out the scraggly bits in the middle and actually retighten them, so tighten them up a lot more than what they were before. So is that a good thing? It's never been seen on functional as being a good thing so far. And on top of that, you're going to then include the risks of surgery. Now, as I show, the anecdote of Carzola, so if he hadn't had surgery, then he might not have had that time out of sport. He might not have. So it's you have these concerns as well. There's one on Twitter the other day where someone had a tendon operation 10 years ago, and they were showing a tophaceous gout that occurred as a consequence to the suture material within it. And I have operated on a lot more removal of suture material as a consequence to people repairing ruptures than I have Achilles recently. Which you then go, okay, there's a big risk. And the other thing I would add to that is that if you are going to repair, doing non-absorbable sutures, you are adding the risk in that you may require to remove that if they get infected. And that is a disaster.
And Lyndon, what is the trend among the BOFA's group of surgeons? What is the trend? I mean, suppose you take 100 surgeons, and is there a difference between private practice and the NHS? Is there a tendency to operate more on, just curious.
So in BOFAS, it seems still to be 50-50. I don't know why. And I don't think that is private practice because what you get paid privately in the UK for an Achilles is very low. It's not great. There's a big difference between us and US which are paid a lot of money for it. So I do feel that there's a big difference on the US side than there is in the UK. Even so, like there was one on LinkedIn about 2 years ago where someone was saying this patient was adamant they didn't want a scar, and so I've done an MIS Achilles tendon rupture. And my response was, why did you do one at all? And then it was a to and fro. Well, the functional results prove it. The patient wanted it, but you said they didn't want it. So it's then you go down that line of it's what are we really doing the operation for? Is it to make us feel better, or is it the patient? It's for the patient. And I
Exactly. Yeah, that's
psychology-
what I wanted to ask you, because the trend among the American surgeons, I've hosted a couple of American surgeons on a very similar topic, was to go for an MIS repair. I mean, you have those new fancy jigs that have come out.
Yep.
I think it's Arthrex or something.
You can see now, so the data I showed, even on our BOFAS registry, the MIS are still no better than the non-MIS. Yes, the conservative. So just doing an MIS because it's MIS, but again, you're putting in suture material. You can take out the sural nerve; it's right there when you're putting them percutation suture through, and you've got like sort of undissolvable sutures within your tendon, so it's still a risk. Now, the main part for me for the reason to operate or not is the psychology, and that's where the studies I think needs to go now. So I had a Cirque du Soleil gymnast, and I showed her all the evidence. She's a very bright girl, and she said, "I get it. I know there's no difference. However, I feel I cannot rehab this unless I know there's something holding it together." It's fine. So I had no problem with doing an acute repair on her because it was quite clear that she had a reason for it. And I think there's definitely some scope within the literature to look at the psychology of can or will athletes do their rehab if they
what, Lyndon, I think it's a general psychology among the public. If you have a rupture, repair it. It comes to the rotator cuff everywhere. I mean, if there is something, a major rupture, when we talk about tender Achilles, it's a complete rupture, right?
Yeah.
So the normal psychology among the public is, okay, you have to repair, otherwise it's not going to work.
I know, but I guess having been in to many long tendons, delayed rupture long tendons, there's always a tendon. There's always a big tendon. There's very few that sort of have got a big gap. So I had one the other day that had a gap, but usually there's a big tendon structure attaching from the calcaneum to the gastroc, but it's long. And you watch them, they've got the loss of tension, and you just need to take the section out. But there is a tendon there. So this concept of, well, I can't heal, you do heal. And actually, if you do treatment functionally, is theoretically, you're going from this tendinopathic tight Achilles to a less tendinopathic, non-tight Achilles. That's going to be a lot less painful and a lot more functional. So I know that I've got this bias, but I also got the bias based on the fact that I have a very good Achilles clinic.
No, it's great because you have put the evidence, what's available, right? So that's great. And what about chronic ruptures? One surgery that you would go for, FHL transfer?
Yeah, so I've now over the years I've now migrated to what is something that I know is very predictable and in my hands has very good results. So I do depending on whether or not there's a gap, whether or not I'm taking stuff out. And so I'll take a section of Achilles out and fold it open. Open up your FHL sheath in front, pull on your tendon, and sort of cut your FHL and do the FHL transfer, because then that controls your tension, because you know your foot's in the right position and it's controlling tension. And then I do what is called a box graft, where I pass a allograft, usually a 25 centimeter semitendinosus, and I keep on passing it until I run out of tendon. That's my biological graft. And I usually find then by, when these patients come back at 6 weeks, 3 months, you can see the power. So they can already do even at 6 weeks, you can see that they can do a one leg stance, and they feel this power is back for them. So for me, that's my go-to.
And Lyndon, do you think there's any role for the peroneus longus? A lot of us sports medicine surgeons have been harvesting the peroneus longus. leaving the brevis there. So I saw the gap and I was immediately wondering, okay, why not the peroneus longus? Because some of as I already using it.
So I use FHL as my transfer because two reasons. Number one, it's right there. So if you don't open up the FHL sheath, essentially when you try to repair your tendon, it's very difficult to close the top end. If you open up the sheath, it's much easier to close the top end. So I'm opening up the sheath regardless. And it's right there. So you can just pull on it and it goes straight into the Achilles. So it's you don't have to make any other incisions. So that's my main reason for it. There's quite a lot of evidence on the FHL. So, but the main reason is that it's right next to where I'm doing it, and I'm going to open up the sheet anyway. So that's why I'd use FHL all the way.
And your any opinion on the peroneus? See, I don't know whether you've seen a lot of sports medicine surgeons taking the peroneus longus.
The push off power you require peroneus longus, because what you'd be doing then is taking your push off power from your forefoot, what then controls your foot in its in your propulsive phase, and putting it to your Achilles. Now the FHL doesn't control your midfoot, so it controls your toe, and also because you're not of Henry, you're often you'll see the tendon actually works afterwards anyway. So taking your peroneus longus, I think, would be a detriment theoretically. So in the UK, is peroneus longus is not it's not normal to take peroneus for this.
For these multi-ligament knee injuries, I mean, is there a trend?
So our units, so if they'll take the hamstrings from the other side, they'll start using allografts. I tend to use allografts just straight off. My unit is happy for me to do it. We used to take the hamstrings, but you imagine you either trying to take a hamstring when they're prone or the leg is prone. It's quite difficult. So it saves you flipping the patient, saves the morbidity and such. And so I will use an FHL. Semitendinosus from the shelf.
Thank you, Lyndon. Lynn, I think that's all the questions that we have for this session. Thank you for yet another brilliant presentation, and really look forward for more in the future. Thank you so much.
Thank you for the invite.